Welcome to this briefing on dialysis payment changes and the cardiovascular health, navigating risks and supporting innovation. This briefing builds on our previous discussion of dialysis payment changes by examining how recent developments may affect cardiovascular health, patient access, and the continued advancement of innovation. National Forum briefings aim to present multiple perspectives without bias on timely policy issues. This event is brought to you by the National Forum's Value and Access collaboration, which receives support from Ardelyx, AstraZeneca, BMS-Pfizer Alliance, Novartis, and Regeneron. The implications of dialysis payment policy extend well beyond kidney care. Cardiovascular disease remains the leading cause of death among people with chronic kidney disease and end-stage renal disease, and making the delivery of high-quality, coordinated care essential for this population. Because payment policy influences clinical practice, access to therapies, and the adoption of new innovations, changes to the end-stage renal disease prospective payment system, and the dialysis payment bundle have the potential to affect not only kidney health, but cardiovascular outcomes as well. As the dialysis payment landscape continues to evolve, policymakers, clinicians, patients, and other stakeholders are working to better understand how these changes may influence patient care. Questions surrounding access to innovative therapies, care coordination, and the long-term sustainability of high-quality dialysis services have become increasingly important. At the same time, there is a shared goal of ensuring that payment policy supports innovation while preserving access to comprehensive patient-centered care. Today's panel brings together leaders in nephrology, internal medicine, patient advocacy, and kidney health policy to examine these issues from multiple perspectives. We look forward to a thoughtful discussion about the opportunities and challenges presented by recent payment changes and what they may mean for patients, clinical professionals, providers, and the future of cardiovascular and kidney care and health. With that, it's my pleasure to introduce our moderator today, Dr. Carolyn Koenig. Dr. Koenig is an internal medicine physician and the physician quality lead with Mercy Primary Care in St. Louis. Dr. Koenig's also a member of the National Forum's Advisory Leadership Council. I'm grateful for her leadership, and I am pleased to pass the mic to her.
Thanks, John. As a primary care physician here in St. Louis for the last 20 plus years, I've treated many patients with who've been on various forms of dialysis, but I hadn't really thought about how their treatments were funded until recently. So I'm going to share a little bit with what I know in that space to kind of prompt our discussion today. Basically, since 2011, CMS has paid dialysis facilities bundled payments for each dialysis treatment that a patient gets. So that's the dialysis itself, supplies, staffing, equipment use, end-stage renal disease-related medications like IV iron, and ESAs, which are erythropoiesis stimulating agents like Epogen, which help prevent people from getting too anemic when they're on dialysis for various reasons. That's an issue. And then other oral dialysis meds like vitamin D, there's probably others. It includes the labs that they need to get. It does not include physician payments, hospitalizations, non-dialysis related medicines, and then they have some adjustments for how sick the patient is, their comorbidities, their age, et cetera. And I think there are some quality measures that they follow with these dialysis facilities. So since 2011, that's kind of the landscape that dialysis patients and facilities are working through. And then on June 24th of this year, CMS issued a proposed change to those bundled payments for dialysis facilities. For taking care of those dialysis patients that are proposed to start January 1st, 2027. I won't go over all of the changes, but one of the big ones is an increase in the base payment to $299 per session, which will also include phosphate binders, which is a medicine to kind of control phosphate levels in these folks, into the payment bundle as one of those medicines. So far, they've been covered outside of the payment bundle through the patient's Medicare Part D. This amount includes a proposed $15.96 increase to the amount for the incorporation of phosphate binders for these patients in the base rate. The reason for that, and certainly our nephrologist, Dr. Desir, can explain more, is that phosphates aren't fully removed during dialysis. And when those levels are high, it leads to pulling calcium out of the bones and into the bloodstream. That can lead to cardiovascular effects, which we're definitely focusing on today, not to mention other issues like thin bones, metabolic stone disease, fractures. So our stakeholders on our call today hold different views and different perspectives on whether the proposed payment increase is sufficient to support patients' access to phosphate binders and individualized treatment decisions. So before we dive into our expert panel discussion, though, I am going to open up or ask someone to help open up a poll on for our participants today. How would you rate your understanding of the recent CMS payment policy changes and their impact on innovations in kidney care? Okay, so thank you for voting. And we have the results here. Limited, which is 42%, not surprising. I would have put myself there not too long ago as well. Basic, 31%, moderate, 4%, strong, understanding, that's great, 12%. And then expert, that's great. We have some experts on the call. Of note, we weren't able to vote, so I did my vote, and the panelists were not included in that, but thank you for participating. So now I am thrilled to introduce our distinguished panelists. We have Dr. Janice Desir. She's an accomplished community nephrologist, kidney doctor trained in both internal medicine and pediatrics. In addition to clinical practice, she serves as a physician advisor and manager of peer-to-peer services at R1 RCM Inc., leading a team of physicians who assist hospitals nationwide with denied insurance authorizations. We also have Mr. Paul Conway. He is the chair of policy and global affairs and a past president for the American Association of Kidney Patients. As a patient, he has managed kidney disease for 42 years, including 3 years on home peritoneal dialysis, and for the past 25 years with a kidney transplant. We have Mr. Carson Smith, who is a policy analyst with the National Kidney Foundation's government relations team in Washington, D.C. His work focuses on federal kidney health policy and advocacy, helping to advance policies that improve care and outcomes for individuals living with kidney disease. Thank you, panelists. At this point, I'm going to give each panelist a few minutes to share some comments on that they'd like to share with this team. I'm going to start with Dr. Desir.
Thank you, Dr. Koenig, and just thank you for the invitation to be a part of this panel, and really what I find obviously to be a really important topic. And I think Dr. Koenig did a great job for those who have limited knowledge, which is a lot of us, in terms of laying the foundation of how dialysis care works. So I just want to bring you into the lived experience as a clinician. And let me just start off by saying that I think that to talk about end-stage renal disease is to talk about cardiovascular disease. And probably more than 50% of our patients suffer from some type of cardiovascular risk and or outcome. And when I lay that down into more clinical conditions that some of us may or may not connect with, that is your patient who's coming in with a heart attack, your patient who's coming in with a reduced pumping function of their heart, what we call congestive heart failure, your patient who has very bad vascular disease, so their vessels are very injured and damaged, and as a result of that, there is a flow problem. So all of that impacts us on a daily basis. And what that means as a nephrologist or any clinician who's involved in advocating for kidney patients is that the ability to care for these patients who are in failure and or who are pursuing the opportunity of transplantation becomes very difficult, because your quality of life, your life years is not just based on the health of your kidney, but it's the health of your body and ultimately the health of your heart. The heart is the pump that drives all. And if it is not in good condition, that obviously is going to be difficult to manage whatever your chronic condition is. So when we think about dialysis management, which I think Dr. Koenig also articulated, there is a distinction between those who have chronic kidney disease and those who have end-stage renal disease. And I want to make sure I highlight that difference so that you understand what it is for a clinician to take care of our dialysis patients. So chronic kidney disease is those who have advanced declining function, but they have not yet gotten to the level of requiring dialysis, and there are different stages and spectrums. But when somebody reaches that final stage, meaning that their function is so limited that we know they need additional support, the option is either to pursue dialysis and or consider transplantation, depending on the eligibility and the qualifications of the patient. And so when you look at the dialysis patient and what it means to take care of them, ultimately CMS plays a huge role because CMS is the one dictating the dollars. So as Dr. Koenig explained, before 2011, it used to be a fee for service, meaning whatever service the patient required, you were itemizing that. And there's probably about 4 or 5 general categories that we focus on when we look at dialysis management. We look at anemia, the health of their red blood cells. We look at their bone strength, which we call mineral bone disease. We look at the overall cleaning and clearance ability, which is just general dialysis. We look at their nutrition, and social factors obviously have a relevance as well. Because as Dr. Koenig also alluded to, there are some medications that we give that the bundle has kind of adjusted, and one of those being phosphate binders. So phosphate binders is part of our mineral bone disease management. And the critical part of that is that you're supposed to use that every time you eat. And the relevance of that in the most basic sense is there's different types of phosphorus. If you take a piece of meat from the store, and you're cooking that chicken and it is raw, when you're preparing that, there's a lot of unreleased phosphorus that stays bounded, and you're able to clear that a lot more easily. If you are buying pre-made food like your cold cuts and or your microwave meals or fill in the blank, which a lot of us do on a regular basis, but maybe certain communities may have more higher prevalence of doing that. That is what we call inorganic phosphorus, and that has a lot of difficulty clearing. So when you are looking at your dialysis patients and you have an increased phosphorus burden, the need to clear that is important because phosphorus can build up in our vessels and it can cause calcifications, which is stiffening of the vessels. Phosphorus can impact the health of your bones and make you higher risk for fractures. Phosphorus can also just impact your ability for transplantation because of the secondary effects it has on cardiac disease. So when we're thinking about what this means for us as a nephrologist, ultimately, when a payment is being bundled, like CMS is doing, and putting the binders inside of that, what they're really saying is that we are restricting your ability to choose what's best fit for your patient. And instead, we need you to work within the confines of what this dollar amount is. From a cost containment standpoint, that's excellent. But from an actual, efficiency of clinical management, that's like telling all of us who trained in medicine, I'm going to tie your hands and I'm going to give you a limited toolkit that's not in line with what you trained for, but is more so about the dollar. And I want you to keep this person healthy. And so the challenge that we have is in terms of trying to keep somebody the most healthiest, it means you need to maximize the opportunity for all meds to right size fit all. That's not standardized. And not only do you do that, early investment actually saves dollars. But the conundrum is with the bundle, we're not being able to do that. And so as that little glimpse in terms of what we're talking about in terms of managing a patient, I think it's an important topic because in the end, understanding that trying to have healthier cardiovascular outcomes means that we need to be more mindful about what is and is not in the what is and is not in the bundle, such as in binders as an example, is critical for us to kind of take next steps to kind of talk with those policymakers to make them understand the lived experience of what they've set forth in this rule.
Thanks, Dr. Desir. Next, I'd like to hear from Mr. Conway. What would you like to share?
Thank you very much, Doc, and thanks, Dr. Desir. I guess a perspective both as a patient and as a leader in a national organization that's a policy advocacy organization. The American Association of Kidney Patients is the oldest and largest kidney patient organization in the United States. And I think there's a certain passion that comes when you talk about issues that we would classify as government determinants of health. And that's exactly what the bundle is. because in 2011, when the bundle was conceived, it was really designed to address cost overruns in fee for service. So it is a cost containment mechanism, and we believe it's become an anachronism in an age of medical innovation in drugs, diagnostics, and devices. But especially in terms of drugs, and in an era when we're trying to focus on improving kidney health outcomes and saving more lives, we think it's counterintuitive that a policy that's 15 years old could actually be limiting patient access among the most severely impacted patients, patient access to new medical innovations that we have fought for as advocates and marched through FDA and into CMS for payment. Let me just tell you what this is like when you're dealing with high phosphorus. As a kidney patient, I lived on peritoneal dialysis. I have a lot of friends who have done hemodialysis. You're managing your phosphorus every day. You're supposed to take your pills with your meals. You're supposed to watch out for phosphorus. You can manage phosphorus through your diet to a certain extent, phosphate binders, and also variations in the dialysis treatment. But for some patients, the combination of those three still doesn't work. And so the need for innovations for a niche of these patients has been vital. There's a thing that people call pill burden. Some folks are familiar with this, some are not. Let me put it in raw terms. If you're a patient, and we survey our patients, and you take an average of 12 pills a day, that's 4,300 pills per year that you're managing, in addition to any other chronic condition that you're being prescribed for. If you take 20 pills a day to manage your phosphorus, that's over 7,300 pills per day. And just to keep it real, what does that mean? Well, it means that your family needs to carry them with them. Your friends at work need to carry them with them. You need to have them stashed everywhere, and you got to remember to stay on top of it. Because at the core, this can affect your transplant readiness. And so high phosphorus can cause a number of different things that have been mentioned here: cardiovascular disease, mineral bone disease, pulmonary dysfunction. Let me just tell you straight. I had calcifications throughout my vascular system. I've had a heart attack. I have 5 stents. When I was transplanted in 1997, they told me, hey, we're going to manage all these different indicators to assess your readiness, and one of them was phosphorus. And I had to be very particular about that to make certain when I got the call I could take the opportunity. But years later, what evidenced itself was that because the management of phosphorus was not ideal for me, I had a lot of consequences to manage, and I still do. And I'll never forget that. Because we're living in an era when there have been new innovations that have come through FDA that reduce the pill burden for patients and make it far easier, especially for that niche of patients that are extremely difficult to manage their phosphorus with. It's empowered medical professionals to be able to address their needs and to make certain they have an equal opportunity for transplant. Yet, this intervening factor called the bundle, and a decision that was originally formulated in 2024 and announced in 2025, so it doesn't even reflect the priorities of a current administration. When that policy came forward, no patients were engaged or consulted on it. It just came out. And so you have the prospect of new innovations that can address this particular issue now under the bundle payment system. And that bundle payment gets between a doctor and a patient and the doctor's ability to prescribe the right medicine at the right time for the right patient. Our organization, AAKP, opposed the bundle in 2011 because we looked down the road and we thought it was simply insufficient and unimaginative to think that you could capitate payments and cover innovation 10, 15, or 20 years in the future. And we thought that because we've been involved in public policy in the federal government for a long time. And when the federal government puts a policy for payment in place, it's extremely difficult to modify it or move it. And we believe it's counterintuitive to the best instincts of doctors and for patients. We don't think the addition of additional funds in the base rate for dialysis reimbursement is sufficient. And probably the largest thing for us as a patient advocacy organization is national policy right now is transplant first for those who are eligible and save people the grueling practice of dialysis and save taxpayers a tremendous amount of money. That's national policy under multiple presidential administrations. And yet you also have an agency that feels as though it can act to move things into a bundled payment, even if it undermines what we believe are national policy goals and the best opportunities for patients to stay healthy and strong enough as possible to get the transplant for those who are eligible. So thank you for the opportunity to be with you and give a patient voice and an advocacy voice to this.
Thank you. Really appreciate your unique perspective and advocacy for patients. So we'll hear more from both of those speakers in the near future, but first we're going to hear a little bit from Mr. Smith from National Kidney Foundation.
Well, thank you. And thank you to the National Forum for having me today. It's great to get a group together, talk about bundle policy. All of us policy wonks really enjoy it. First, I just want to talk about NKF and the role we play in this as an advocacy organization, a patient-centric organization similar to AAKP. We work all across the kidney care continuum. So there's some really fantastic work done with chronic kidney disease detection and prevention all the way to transplant at the NKF. And our goal is to make sure that kidney patients live the most fulfilling lives they can. And obviously the bundle plays a very heavy impact for hundreds of thousands of kidney patients. So it's important to get groups like this together and get people to start thinking about how the bundle can impact people in their day-to-day lives. I also want to talk, since we're talking about phosphorus a lot, and kind of some other advocacy work we've done at NKF outside of the bundle and current changes to medication coverage. Dr. Desir spoke a little bit about the patient burden of managing your phosphorus and understanding the foods you're intaking and the phosphorus levels in that, and how different foods have different phosphorus levels, and your body can absorb foods from absorb phosphate from processed foods a lot easier. And understanding that, we've been advocating for the inclusion of phosphorus labels on food nutrition labels. So we would have the total phosphorus and add phosphorus, and trying to think of ways to kind of lower that burden on patients to fully manage phosphorus on their own with no help. It would be very helpful for them to understand how much phosphorus am I taking in, or how much phosphorus is in these Doritos, something along those lines, because that really is a great way to limit phosphorus intake and manage phosphorus. And then we can get into the inclusion of phosphate binders and how patients have access to that. And if, very similar to what Mr. Conway had said, we want physicians and nephrologists to be able to connect patients with the right medications at the right time. And that's something we continue to push for, patient access to the drugs that patients need. I'm excited for this panel today. I'm excited to hear what questions people have. It's like I said, all of us policy wonks enjoy this. It's nice to see not that many people are experts or know much about this. So I'm excited to help educate, get people excited about this. And thank you.
Thank you. I had not heard that term policy wonk, but I'm glad, whatever we call it, that everyone else is having a fun time geeking out on this conversation. I'm learning a lot. I did not know that phosphorus wasn't included on nutrition labels, but I'm looking at one now. And absolutely not. It seems like a simple, just do it kind of thing. So I appreciate that. Can one of you all speak a little bit more about the price discrepancy with these medicines and things to consider there? I heard pill burden, concern about these medications being appropriately given to patients because of its bundling. But can one of you speak to how expensive these medicines are?
So I'll make a general comment because I, like you, Dr. Koenig, have learned a lot in this journey. And I think I'll preface by saying, as clinicians, we're taught how to take care of patients, right? And we are not necessarily taught about the finances and all. Maybe that's invested in terms of trying to determine like what are the rules and why is this one approved and this one not approved, when again, like I said before, that you have this toolkit. And I guess to get to the answer of your question is to also take a step back too, and saying that, you know, part of the space of being able to be here with you today is me just finding myself in a position of not understanding that I can have two different patients with the same condition, and depending on where I am, what zip code I'm in, that's going to dictate essentially what I'm capable of doing for treating patients. So it's a big part of why I've gotten involved with the National Minority Quality Forum and the Nephrologist for Equitable Kidney Care, in order to be able to just get to a space of not only knowledge for myself, but advocacy of what the lived experience is. So in the most basic sense, you can consider that some binders, like when you're in the hospital, for those of us who take care of hospital patients or even outpatients, you will have like your sevelamer, you'll have your calcium acetate, and those are like maybe less than $1 or, you know, under $5, but very inexpensive. So when we heard about the bundle being able to have $15, you know that you can get a bulk amount of that for that type of dollar. And then you have some higher level binders. Maybe you have your lanthanum carbonate, or, you know, another alternative where maybe that's like a $10 or something, you know. But then the more innovative binders are going to be like $30 per person. So if I give you a budget of 15, and in a dialysis unit, you often have about 4 shifts for your average chair, right? We're here, you know, I'm here in the New York area. So maybe it's 20 people per shift. Well, that's 80 people on one day, right? Coming through the unit, because that's a Monday, Wednesday, Friday. So that's not your Tuesday, Thursday, Saturday. And that's not home dialysis. So you can have a good couple of hundred people coming through your unit. And what will you do? I think those of us who are not even in the business of medicine understand the business dictates I'm going to gravitate to the one that's a couple of dollars, right? Because I have such a large volume of people that I need to take care of. I want what's cost effective and, you know, what's cheap. But ultimately, it kind of inhibits the opportunity for innovation, because in the end, without taking the best analogy I like to give is just, if there's a storm and the windows are open, but you're trying to mop the floor, is it stopping the water from getting in? Absolutely not. And that's what I find with a lot of these binders. A lot of the more older binders are like mopping the floor with the open windows, and the more innovative binders are really looking more to shut the window, so you're not allowing the water to continue to get in. And when you're doing the effort of cleanup, it's actually a lot more successful. So that is just my quick and dirty kind of range of what the dollars are, more so to give guidance, but not to say that that's specifically the value of each of them. I certainly defer to any of the other panelists if they have, you know, more concrete numbers to offer.
I'll venture out with a thought here. I think what the doctor just characterized is the conundrum, and it's the anachronism. Because what we're talking about here is a policy and a practice that is tethered to what is the cost impact, not what is the patient impact. And again, we're not talking about a massive number of patients. Some of the innovations here are very targeted to folks who have failed on multiple other approaches. And I think the cost issue has to be looked at from this standpoint. You know, obviously, innovation and new medicines will cost more. I think we understand that. We're in a free market society. People get that. But there's a cost that's often ignored and not talked about. And that's the cost to the patient in terms of long-term complications and what they will bring into the healthcare system as higher costs if they're able to survive and live beyond 5 years or 10 years. And the second cost that's rarely talked about is the cost to the American taxpayer. So you can have a short-term view of, hey, I have a $30 drug and a $15 drug. And then you can think to yourself, well, I tell you what, if this person does not progress or cannot be a transplant candidate and return to work and have a salary and pay taxes and be a contributing member to society as they define it, as they choose to, and instead they're on dialysis and living a life of dependency and disability against their wishes, what have you really done? Have you saved anything for the patient or for society? And I think the answer is no. And then when you put the overlay on this of who are we exactly talking about? And let's be honest about this. Kidney disease and kidney failure disproportionately affects in the United States African Americans and Hispanics, and alarmingly at an increasingly younger age. There's no excuse for this. And so the ideal is, again, to take the medicine back to the very essentials of medical practice, which is a trusted doctor, an open conversation with a patient and the right medicine at the right time. And I'm just telling you, having been in the arena for a long time as a patient and as a policy professional, the bundled payment system, the longer it goes without reform, and I'm not talking about nibbling around the edges, I'm talking about fundamental reform, is not patient-centered and it's anti-intuitive to the progression of innovation in the kidney space. We try so hard to get companies to come into this space and find it attractive, along with cardiology and oncology. Rarely have companies come into this space, but now they're starting to. But if you want to drive innovation out and capital out and companies out and human ingenuity and creativity out of this space, stick with the bundled payment system. You'll also lose doctors and professionals who simply cannot stand an environment in which they can't do the right care for the right patient.
Thank you. That's a good discussion. I think it gives a good view of more of this conundrum. This is just an open question for you all. Is there anything that you see that the bundled payment structure helps with? Is there anything that is working well with that, or that people would argue is working well?
I'd say that there's an argument of, what the bundle was designed to do is control costs. And I think there's little argument against that it has controlled costs compared to pre-2011. And I think the reason we have the conversations like this is, the trade-offs of controlling that cost, as Mr. Conway was putting is, you can control costs and what is the result of controlling those costs. But I think, the bundle, the PPS payment system is doing what it was designed to do. And I think part of being in this space and working in kidney disease advocacy is looking for opportunities to improve the system. How can we improve the current system? What changes can be made? And continuing to look for opportunities to make a difference and improve the lives of patients living on dialysis. And I don't know if any other panelists have thoughts on what's working well, but that's kind of the argument of what is the bundle to do well.
This is Paul. I think, Carson has kind of just put a laser on the key fact here. It's a cost containment mechanism, and from that standpoint, it has worked. What is different now in 2011 and what has changed fundamentally in the United States, if you look at that period of time, you have the creation of many different bodies and opportunities to increase patient voice and decision making. You had the creation of PCORI, Patient-Centered Outcomes Research Institute, an entire staffed operation in Washington, D.C. that's supposed to be focused on improving patient health. You've had the advancement of Medicare Advantage, especially in the areas of kidney care, which is also very focused on cost containment. You've had the FDA, you've had NIH elevate the role of patients in their lived experiences. You have national bipartisan policy that has said we need to move care upstream and prevent the progression of kidney disease. So what you have to ask is in 2026, with all of these factors and all of this advancement and all this focus on reducing the burdens on patients and taxpayers, is a payment system designed 15 years ago inside a federal agency outside Baltimore, Maryland, really flexible and creative enough to match where we are today as a nation? And we would say absolutely not.
Good points, everyone. Yeah, I think maybe for some that are newer to this, I think I'll just kind of summarize what I'm hearing is prior to 2011, largely because dialysis centers are for profit, maybe they were overutilizing medications and treatments, arguably that didn't need to be used because they could potentially get more profit on that. And I believe that part of that was related to the ESAs, the erythropoiesis stimulating agents. Have we learned anything from that? Like, can anyone speak to the decreased use since 2011? Was that the right thing? Or did that get to a sweet spot in terms of balancing the right med for the right patient at the right time? What have we learned from that? Because I kind of compare like the fast finders to that.
I guess I think what the literature shows is I mean, you laid the foundation in terms of overuse of higher dollar amounts, right, for added financial gain. And when that was stopped, then you saw an increased incidence of adverse events in the most basic sense, because it wasn't as if the cessation of those high dollar medications led to a different form of innovation. It led to essentially lower tiered options that wasn't really optimizing, to me, ideal patient care. So we see it more with calcimimetics. And when, calcimimetics were another class of medication that used to be, it used to be essentially you would get an added kind of financial incentive to use them. And then when they switched over and they started to use more kind of standardized medication, then you saw increased adverse events in terms of mineral bone disease, in terms of fractures and secondary effects, with increase in worsening vascular calcifications. So we see the difference. And in the end, it's just adverse patient outcomes. And I guess a space that, I find very important, and it kind of alludes to what a lot of our other panelists have been saying, but just more concretely, 20% of health outcomes is driven by social drivers. It is 20% only that is truly a truly kind of genetic or kind of organic medical issue that is going on. That is a big deal. You're saying where people eat and where they work and where they play is really where a lot of the adversity comes from. And I think in the kidney space in particular, because nutrition is just as big of a component as stress is just as big of a component, and these are just all chronic-ish things that the renal patient is dealing with, that it becomes even more compelling when we're kind of focusing on the subject matter of the phosphate binders, how difficult it is. You're asking somebody to essentially, I don't just eat or see patients eat, one time a day at the dialysis unit. They eat multiple times a day in their homes, and you're having a center that's not really equipped to essentially be a pharmacy in terms of oral medications, manage that. You're restricting the arsenal of options of what they have based on their, attempt to try and cost contain. And you're doing it all at the effect of decreasing kind of like, life years in a patient. I think it was well said earlier, the idea that policymakers are the ones making such decisions when they weren't the ones who are necessarily trained, like the clinicians, it gives you food for thought, and it gives me pause. Because I know those of us who took the time to train, we took it with an oath to seriously honor and to do our best to take the best care of those that we can. And to not only do that, there's a lot of time, years, and effort, and I'm sure Dr. Koenig will agree, in investing in that clinical education. So this idea that those who don't fully understand the scope of their decisions are making choices that have been so articulately expressed that have such adverse outcomes for patients, and just really challenges for those who are trying to be in the space of advocacy to kind of overcome. There's a disconnect is ultimately what I want to say. There's a disconnect. And until we can find the right kind of bridge where we can maybe balance some of this concept of cost containment in the reality of the lived experience of what it's like to care and ultimately be the kidney patient, that's when we're going to hit the sweet spot. But right now, it doesn't seem like a lot of the social drivers are really kind of being highlighted, and how much that truly impacts the kidney patient. Like, it is not just you have kidney disease. You must incorporate the other factors to be holistic in any kind of plan that you offer for optimal treatment for our renal patients.
If I could add something to Doc's comments, which I think are just spot on. I lived on ESAs when I was on dialysis. And when I found out my kidneys were failing and I had to go on dialysis, I was working full time. I had just bought a house. And in full credit to my nurses and the social workers and the doctors that were engaged in my care, ESAs are what allowed me to stay employed. Because dialysis is a tough grind. Before you go on dialysis and your kidneys are failing and you're trying to get a transplant and it doesn't work out, it's a tough grind. And so ESAs, in my experience, were able to help me stay engaged and stay employed. And it was just a few years after that experience of being transplanted successfully, um, that I had the opportunity to speak on the proposed rule on limiting ESAs and bundle at CMS. And I gave my viewpoint for AAKP. I was representing them, that I thought that it could be an overcorrection on limiting access, and the overcorrection could negatively impact healthcare professionals because I remember my dosing was graded and would change. And I thought taking away that flexibility wasn't right for patients, but especially not for the doctors. And so I think when you think about this, one of the lessons learned, and Doc talked about this quite well, is when you have policymakers and federal officials who have absolutely no certificate or degree in the field of kidney disease and kidney medicine, that's a big red flag. The second thing is to understand fundamentally the power of the federal government is massive. And when the federal government makes an overcorrection, it can have tremendous downstream negative consequences. And coming out from underneath that takes years. And that's why the fundamental shift over the past decade of increased patient voice at the table with policymakers has been vital. And that has come through a variety of different ways. Secretary Azar, under the first Trump administration, had a father that was on dialysis and he wanted him to get a transplant. And he realized the only way that his father could get a transplant is if he brought him home, dialyzed him at home, and became his chief advocate in the system. And he did that because his father was very ill. And it's a good lesson there to understand that patients at the table make a difference. Uh, but CMS has never been consistent on having patients at the table, to be quite honest with you, in our viewpoint. And when they go through different leadership transitions, you have to have those same battles all over again. In fact, Secretary Azar spoke to AAKP several years ago, and he said there are no permanent victories. There are only permanent battles in the field of kidney medicine and kidney policy. And we would agree with that. And this is an important one because what we're trying to do is advance innovations that save lives, reduce burdens for patients, and ultimately reduce burdens for taxpayers. It's an optimistic story. And you have doctors that have spent years in the arena getting these credentials and that patients trust. And the idea that one patient could get one drug and one patient couldn't, separated by either a zip code or anything like that, a construct the doctor didn't create, it tells you there's a patchwork quilt to healthcare and kidney care in the United States, not by making of the doctors. And that patchwork quilt, we believe, is what drives equity discussions in inequities in care and outcomes. And it's sad. It really affects you as a patient because you wonder, will this person get the latest innovation and have another 2 or 4 or 5 or 10 years, or will they not? And, again, that's why we label these things government determinants of health. We think it's appropriate. There's social determinants of health. That means society. Government is a big part of society, and they need to own and be accountable for those things that they do that injure patients.
And if I can, I'll just add another perspective
Absolutely.
on the or angle for how the bundle is sometimes overly rigid in how it regulates dialysis care. So it really is set up for the in-center model, meaning patients going 3 days a week to in-center facility and receiving care for 3 or 4 hours. Um, and something that we push very heavily for at NKF is home dialysis and modality treatment options. Um, you know, yeah, as you can imagine, the fluid intake and offload between dialysis and at dialysis sessions, it can be, 5 to 10 liters. It can really wreak havoc on the cardiovascular system, which is why I bring it up at this panel at the National Forum. It really can cause major cardiovascular issues, and it's an issue completely separate from drug coverage that we've been talking about. Is if we can get patients access to modalities that are gentler on their bodies, match what their quality of life and life goals are, we can really make a difference in these people's lives. Giving them better outcomes, allowing them to live the lives they want to live. You know, the bundle really forces us into this model that, you know, you go to dialysis 3 days a week, you sit in the chair, and you leave feeling fatigued, and you have all those symptoms of dialysis. And, you know, how can we reshape this bundle, this model, to work for patients and allow them access to peritoneal dialysis or home hemodialysis? You know, what training, what supports do we need to make that a reality for more patients? Because in the United States, we have less than 20% of our patients on home modalities, and compared to many other countries that are closer to 50 to 70% on home modalities. You know, it's a big difference. And it's something that I think we can, you know, make change and affect change in, to kind of really benefit our patient population, and make their lives that much better.
That's a great call out. I think as an internist and through all the training we've had, you know, we learn about the different modalities for treatment of end-stage renal disease, but like mentally, always people are thinking of hemodialysis 3 times a week. That's where everyone lives. But getting upstream of that conversation, presenting options earlier, you know, a lot of what I do in primary care is advocating and putting things in place for earlier detection of kidney disease. So we're having those discussions, preventing it or planning more. That's key, and it does impact cardiovascular health from the get-go. Someone mentioned in here, kidney disease is a cardiovascular issue as well. Absolutely. And I think there is more attention to what we're now calling cardio kidney metabolic disease going forward. I hope that will help. We are at a point where we can open to audience Q&A. Are we doing that just in the chat? Certainly enter any questions you might have in the chat. While we're waiting on that, any contributions from the audience on questions? I will throw out one more for our panelists. If you could recommend one change or safeguard to policymakers as the dialysis payment system evolves, what would it be?
I'll throw one out. This is Paul. I think
Yeah, it's gonna hard to limit you to one, probably. There's
it
so
probably
many.
is, but I
Yeah.
tell you, this is one that I do think we're seeing progress on it, which is positive. But I think closer coordination between CMS and FDA, so that CMS is fully aware of things that are coming down through the regulatory pipelines for approval that have implications not just for kidney, but you mentioned this, the cardio kidney metabolic syndrome is being talked about more and more. So being able to take patients out of silos and look at the whole person, I think will drive the conversation about what are we doing to treat the whole person, including cardiovascular events and metabolic events, and come up with more common sense policy where the dollars follow the person and the dollars are informed by the clinicians who are the experts. That flexibility has to be built into it. We're optimistic about it because this is a growing bipartisan viewpoint in the Congress. It's one of those rare things that's above 100,000 feet in a lot of the fray. But you have people that are working really hard to figure out in industry and in government and in research centers, hey, why is it that we're treating and paying in one way that's in many ways we believe outdated, but the person themselves can benefit from these new innovations that can treat all three things. The other thing we feel very strongly about is there should be a national recommendation on screening for kidney disease. The U.S. Preventive Services Task Force, we believe, has been asleep at the switch for 20 years. We believe that they're going to be shook up pretty soon by the secretary. There's a lot of criticism about that, but we see it as an opportunity as kidney patients because we would like to see nephrologists on the USPSTF. We would like to see the science and the research that has been done for the past 20 years in that field given full attention. And let's get some screening recommendations in place for those most at risk so we can have the conversations about upstream and it can be more uniform. We can save more lives, and then clinicians don't have to feel as though, hey, there's not a recommendation in place. I don't want to fight the insurance company for this or that. We can have common sense policy, and I think we can all agree on that. That's good for medicine, it's good for research, it's good for patients.
Thank you.
So I agree with everything that Mr. Conway just said. If I would add one quick thing to add to that from my perspective, I think there was a movement very much in the health equity space with a lot of focus on social drivers. And I feel like this current administration has taken a pivot in terms of wanting to be more inclusive, and as we should be. I would say, as a clinician, there is a distinction between a social driver and a health related social outcome. And I don't feel like we talk enough about that amongst policymakers. A social driver, as we said, is a societal influence causing a problem. But when that societal influence has an adverse effect on your health, that is a health related social need. And so to circle back to the question, I wish policymakers were more aware that there are health related social needs impacted by social drivers, that all clinicians and really anybody in an advocacy space should understand the difference and the distinction. Because back to what Mr. Conway said, there are medications and I think plans of actions that can be more holistic. We're too much in a this, or if your heart is the issue, you just do this for your heart, and you do this for your kidney, you do this for your lung. But really, our bodies are like trees. What is happening in the roots is going to eventually manifest on the outside. And until you do the root cause, which is really to do a holistic cause, right, it is not really a piecemeal type of thing. So I think if policymakers were more aware that when they're making some of these decisions, it may be a kidney adverse outcome, but it is a multisystemic issue. And if your innovation and next steps and really truly holistic care is being also multisystemic in your kind of plan of action and in your care plan, that is a more broad perspective, but at least from a clinical perspective, I have never once had a patient where there's only one thing I'm focusing on, even if there's a primary symptom or problem that needs to be translated into policy decisions as well.
And I guess I'll add as the last panelist here is, as you can probably tell by my last response, I'm a big believer in home dialysis, and I think if I could wave a magic wand, it would be helping to relieve some of those barriers to home dialysis. What can we do to help patients get to home dialysis? What does that look like? Is it, time limited staff assistance as they make that transition, so they, have someone in their home with them for a month, 2 months, 3 months while they learn, they train, they become more confident, overcome the fear of dialyzing themselves. Does it look like home readiness supports and modifications to make sure their home has the electricity and water needs to self-dialyze? I think there's things, policy levers we can pull to make that a reality for more patients. And I guess that's what I would use my magic wand for, is to pull those levers and try to get more patients onto modalities and kind of reap the benefits, increased quality of life, gentler options on the body for dialysis.
I think that is a good segue into Dr. Jones's question. He says there's a major requirement for ongoing education, especially home dialysis probably, for patients with renal disease. Are reimbursements for time, resources spent on education adequate enough to support greater patient needs in that space? I'm going to guess no, but I really don't know.
It's hard to limit myself, but let me say this. I think Dr. Jones has raised a great point, and it ties directly onto what Carson was just talking about. And so we don't, AAKP, we don't believe that the reimbursement is strong enough. And the other thing is, we believe there ought to be multiple times that patients are asked and educated on this. When you're first going into kidney failure and you're going on dialysis, your world is upside down, your house is upside down, and chances are your judgment can be off too because you're very sick. You have a lot of toxins in your system. And the point of education needs to be ongoing, and we believe reimbursement should be flexible, a greater amount, and ongoing as well, because what happens is a patient sometimes is not given the full range of what their options are. And the goal here is to align exactly what Carson is saying. You want to align treatment to the person's aspirations. Maybe they're still working and have to keep working to provide for a household. Maybe they're working on a secure retirement or trying to finish a degree or a credential in a trade or a craft. And so if you don't have that conversation with a patient, you can assign a patient to one form of treatment that's completely counterintuitive to what they need to do to stay involved for their family and be responsible. So we would like to see it increased. We would like to see it routinized so it happens at multiple junctures because we believe that this would invite conversations about transplant that are really conducted with patients that might be seen as not ready or not capable of handling a transplant, but they're not asked, or they're asked at an inconvenient time. And it gets beyond, we believe, what we would call the toe grab. So, you come in, the doctor comes in, you see the patient, grab him by the toe. Hey, here are your options. Check off the box. I get the reimbursement. And that's for doing something that you're required to do. It's not about having a conversation that's ongoing about the best for the patient. And so we think there's a lot of room to improve that. And we know it's the good intentions of most medical professionals. We just think they ought to be paid commensurate with the work that they're doing. And we just don't think it's enough. Thanks.
And I'll add that was a great coverage of once you're on dialysis, how does education happen and how we can continue it. And something we push for is even before people get to dialysis, how can we educate them, on all things kidney disease? We champion legislation, the Kidney Disease Education Expansion Act. It would expand this reimbursement to cover people with CKDs, all stages CKD plus hypertension and diabetes, the main causes of CKD. And it gets at the point we've touched on a little bit, but we haven't really dove into is detection and screening. But education is key to a lot of these things. And how we can push that forward and reimburse it in a way that works and really makes a difference is the key there.
Thanks, everyone. I think we could talk more on this, but I think we are running to the end. Do we have time for the poll and then closing comments?
Yes, let's do the poll.
So post forum discussion, how would you rate your understanding of this recent CMS payment policy changes now and their impact on innovation in kidney care? We are up to 59% moderate. I think that's good. Hopefully you all gained a little bit more knowledge or insight into this. I know I did. So thank you to our panelists. And John, can you close us out?
Well, thank you, Carolyn Koenig, Janice Desir, Paul Conway, and Carson Smith. You moved the needle. We have improved awareness, understanding of the issue, thanks in large part to your sharing your insights and for your comments in this informative briefing. You've illuminated an issue that has been largely unseen, but you've helped us understand today that it affects real people's lives and their well-being. The economic picture is multidimensional with cost containment, as Carson pointed out, and on the other hand, huge consequences for families, communities, and society, as Paul pointed out. We heard today that it means the difference between someone remaining employed, supporting a family, and paying taxes versus becoming sidelined and suffering. So there are both economic and moral components here. We heard those, the latter come through, the humane concerns and interests that I think we all share. I was certainly very pleased to hear the comments that were spot on about the importance of the vital conditions for health and well-being. And without those vital conditions, it's very challenging, very hard for someone to even have the opportunity to attain optimal cardiovascular, metabolic, and renal health and well-being. Now, while this issue may not be a bright blip on most advocates and policymakers' radar, it could affect the health and well-being of some of the most vulnerable people in our communities significantly, as we've just heard. The National Forum will submit comments to CMS on the proposed ESRD prospective payment systems update next week. I urge you and your organization to submit comments too. The National Forum will email a copy of our comments to everyone who registered for today's briefing. So please feel free to use these comments as a model or a template for your own comments. And remember, the deadline to submit comments to CMS is coming up quickly. It's August 24th. Now, I want to thank the sponsors of the Value and Access Collaborative, Ardelyx, AstraZeneca, BMS Pfizer Alliance, Novartis, and Regeneron. Their support makes it possible to present this briefing to you without charge. With that, thank you for joining us. Let's continue working together to ensure that everyone everywhere throughout the United States has the opportunity to attain optimal cardiovascular, metabolic, and renal health and well-being.